Hello, everyone, and welcome. First of all, I must thank the Extempore team, particularly Daria and Tatiana, for this wonderful opportunity. And I must also thank Dr. Ashok Khurana, sir, for having connected me with them. I've been asked to speak on the ultrasound hints to trisomy 13 and 18 in the first and second trimester, and I have no conflict of interest to declare. So trisomy 18 and 13, we know, are the second and the third most common aneuploidies after trisomy 21. And if you look at statistics, the prevalence of these taken together is far less than half of what trisomy 21 makes up. But having said that, we need to understand the statistics that for every 3 trisomy 21, you have 1 trisomy 18, and for every 7 trisomy 21, that is when you have 1 trisomy 13 case. Now, the other information that you can glean out from this graph or graphic is the fact that when you look at the live births of Edwards and Fatau, the trisomy 18 and 13, the live birth prevalence is far lesser when you compare. The live birth is what is shown in light blue here. It's far less compared to the proportion of live births that you have for trisomy 21. Now, the reasons for this could be, one, because 18 and 13 are far more lethal in utero than Downs. Second, your terminations tend to be higher because they're lethal in omnis. And third, even if you're not in a situation or in a place where there is the practice of a multimodal screening protocol, where you employ the combined test or the NIPT or so on and so forth, even without any of these, the detection rates for trisomy 18 and 13 are far higher compared to those of trisomy 21. The reason being, unlike trisomy 21, trisomy 18 and 13 are essentially ultrasound diagnosis. Now, which means, unlike the so-called soft markers of trisomy 21, the ultrasound markers in trisomy 18 and 13 are not really that soft. In fact, they're very hard and robust markers, so that these conditions are much more amenable to ultrasound diagnosis than trisomy 21. And that's precisely what this lecture is going to talk about. We're going to look at the ultrasound hints to trisomy 13 and 18 in both the first and the second trimesters. Now, first things first, in our parlance is always first trimester first. So let's look at what the ultrasound hints to trisomy 18 and 13 are in the first trimester of pregnancy. The first and most important sign or clue is early fetal growth restriction. We know that fetal growth restriction in the first trimester is defined as a CRL of less than 5th centile in a woman who has otherwise been well dated. Say, for example, she has excellent dates, her periods were regular, or she's an ART conceived pregnancy. You're very, very sure of the date, but there is a small discrepancy in CRL, and the CRL falls below the 5th centile. That tells you that this fetus is growth restricted as early as in the first trimester. Now, this is one of the early papers that looked at growth restriction in aneuploid twins. And what they found out was there is a growth deficit of at least 6 days for trisomy 18 and 3 days for trisomy 13 as early as in the first trimester, between 10 and 14 weeks of gestation. Another paper which came up with a very similar conclusion said that this growth deficit is very apparent when it comes to trisomy 18 and 13, but not so for trisomy 21. In other words, the CRL corresponds to gestation age in trisomy 21, whereas in trisomy 18 and 13 is where you have the very remarkable deficit in early growth. And the paper also said that if the CRL is shortened by at least 14 millimeters or so, the odds ratio for aneuploidies in that particular fetus is 9, which means that there's a 9 times higher risk that a fetus whose CRL is shortened by more than 14 millimeters could end up being aneuploid on testing. The second important point is, of course, increased nuchal translucency. Now, there are 2 things that the mixture model of NT from the FMF told us. First, the proportion in which the NT increases with CRL is very, very clear. And this proportion, the rate at which NT increases for CRL is pretty much similar in euploid as well as aneuploid fetuses, but a far lesser share of aneuploid fetuses follow this distribution, which means most of these aneuploid fetuses do not show a change in NT with CRL, Not just that, the median NTs are much, much higher than euploid fetuses. For example, euploid fetuses have a median nuchal translucency of around 2 mm, whereas trisomy 21 it is 3.4, in trisomy 13 it is 4, and 18 it is 5.5, of course the highest being for Turner syndrome at 7.8. So which means even bigger an impact does nuchal translucency screening have than when you consider trisomy 21 screening, because trisomy 18 and 13 are conditions that show higher delta NT when it comes to the first trimester. So if I were to tell you that all of these are aneuploid cases, and I tell you that the NTs are 2.5, 6, and 3.8 in these instances, and I ask you which of these have which anomaly, the likely answer would be that this is trisomy 21, this is trisomy 18, and this is trisomy 13. But I can tell you all 3 of these fetuses had trisomy 18, which is because this is not an absolute rule. It is not that every baby with trisomy 18 will have an NT of 5.5 or more. There could be even nuchal translucency of in the normal range for some trisomy 18 fetuses, but by and large, the nuchal translucency is far higher in trisomy 18 babies, more than those that you see in trisomy 13 and trisomy 21. And which is why obviously the median nuchal translucency value in trisomy 18 is around 5.5. Now remember, the spectrum of increased lymphatic fluid is not restricted to just an increased nuchal translucency. You could also find jugular lymph sacs, you could find cystic hygromas, you could find effusions in the body compartments, and sometimes even frank hydrops fetalis. Now the third clue that we want to speak about is unossified nasal bone. Remember, unossified nasal bone is not an exclusive component of trisomy 21. Yes, trisomy 21, more than 65% of more than 2/3 of babies with trisomy 21 do show an absent nasal bone. But also remember that more than half of fetuses with trisomy 18 and more than 1/3 of fetuses with trisomy 13 also would show an absent nasal bone, or rather would not show the nasal bone, which is more correct in saying. Now, this is another paper from Kipros's group that also said the same thing. They in fact quoted a 45% rate of absent nasal bones with trisomy 13. So again, more than half of trisomy 18s and more than 1/3 of trisomy 13s will not show ossification of the nasal bone in the first trimester. So the next time you do not see the 3 lines in 3-line sign, or you do not see the 2 dots of the retronasal, the premaxillary triangle, yes, certainly think of Down syndrome, but also think of trisomy 18 and trisomy 13. We next come to ductus venosus as a pointer in the first trimester. Yes, again, ductus venosus AV reversal is not just a prerogative of trisomy 21. In fact, it's more commonly seen in trisomy 18 and equally seen in trisomy 13 as well. So it's not just about Down syndrome, it's also about these 2 aneuploidies in the first trimester. Quite unlike tricuspid regurgitation, which of course is clearly more prevalent in trisomy 21 fetuses. But again, remember, more than 1/3 of all trisomy 18s and 13s would also show tricuspid regurgitation. The 6th point in the first trimester is fetal heart rate. We need to understand that more than 70% of fetuses with trisomy 13 or Patau syndrome will show fetal tachycardia in excess of 180 beats per minute. And this is a very, very important differentiating factor between trisomy 18 and 13. Remember, these babies would otherwise show very similar markers in the first trimester. One clue that can help you differentiate trisomy 13 from trisomy 18 is the fetal tachycardia component that you see exclusively with trisomy 13. The reason you see exclusively with trisomy 13 is because of the nature of cardiac anomalies that are linked to trisomy 13. Trisomy 13 mostly predominates with left heart outflow obstruction. Now, this reduced flow through the left heart is sensed by the baroreceptors in the left outflow tracts, and that is what mediates tachycardia so as to maintain adequate cardiac output in these fetuses early on in the first trimester. So that's the reason you have tachycardia in trisomy 13 in the first trimester, not in trisomy 18. It's got to do with the nature of cardiac anomalies in trisomy 13. Now, this is a very important distinguishing feature, as I said, and the fact that this is so important is very clearly highlighted by the fact that if you add on fetal heart rate to the screening protocols for trisomy 13, there is a significant leap in the detection rates from around 77% with age, NT, and biochemistry to 87% if you factor in fetal heart rate into the algorithm as well. Now we come to structural anomalies in the first trimester, which could be pointers to trisomy 18 and 13. Of course, there are certain key areas that we need to identify. First, of course, is to look at the brain, the face, the heart, the abdominal wall, the bladder, hands, and feet, because these are the areas or locations where clues to trisomy 18 and 13 are going to lie, and therefore you need to make it mandatory that you look at all of these with renewed interest, with focus, intense focus, that you do not miss out on any case of trisomy 18 and 13 in the first trimester. Now, firstly, let us look at the brain. Now, remember, the trisomy 13 has got a predilection for anomalies of the midline. The reason for this is that there is a gene called SIC2 gene, which is crucial in midline development, including ventral induction and prosencephalic cleavage. Now, this SIC2 gene is located in the long arm of chromosome 13, which is why when you have trisomy 13, there could be abnormalities of SIC2 gene, and that in turn could lead on to the most classical finding of trisomy 13 in the brain, which is holoprosencephaly. So characterized, of course, by a single midline large monoventricle extending from side to side, fused cerebral lobes, cerebral parenchyma, and of course fused thalami as well. So there's fusion of the prosencephalon and the diencephalic structures. There is a single large monoventricle, and of course often fused choroid plexus on both sides could also be seen. So that's a very typical feature of trisomy 13. Particularly, remember, it's only the A-lobar variant of holoprosencephaly that you might really identify in the first trimester. Now, having said that, the midline abnormalities in trisomy 13 in regards to the neural tube need not be restricted to holoprosencephaly. Sometimes you could also have spina bifida in some of these cases, as you can see in this picture. In this fetus, it turned out to be trisomy 13 and had an open spina bifida and no holoprosencephaly. Now, there's another gene called the TGIF gene, which is also responsible for prosencephalic midline cleavage. And this particular gene is located on chromosome 18. So, which is why in trisomy 18 as well, occasionally you could come across holoprosencephaly, as we had seen in this particular case. Now, the second area that you would want to focus on is the fetal phase. Now, remember, the most important thing to look for in the fetal phase is the presence of midline clefts, which again would be a pointer to trisomy 13. Whereas you could also look at the side profile of the phase, where you would find micrognathia, which is a hallmark feature of either trisomy 13 or 18. So that's the most important things to look for in the phase. And then we come to the heart. And in the heart, of course, there is a constellation of abnormalities that you would see in both trisomy 18 and 13. Not really much to choose. In fact, more than 75% of these babies would show some of the other cardiac defect. But having said that, there's a slight predilection of AVSDs and left outflow obstructions in trisomy 13, whereas in trisomy 18, there is slightly more predilection towards septal defects, specifically ventricular septal defects, sometimes large ones, and the double outlet right ventricle kind of outflow tract anomaly. We then come to the clues in the abdominal wall. Remember, the classical finding in trisomy 18 is an omphalocele. Particularly the omphalocele minor is the one that has got a higher risk of aneuploidies. And remember, trisomy 18, the incidence is 62 to 75%, whereas in trisomy 13, slightly lesser, in fact, significantly lesser at around 11 to 25%. So when you see omphalocele in the first trimester, trisomy 18 is the first thing that you should think of. And then, of course, also consider trisomy 13. That, of course, would depend on the other markers that you see in the fetus. And then we come to the bladder. In the bladder, the most classical finding in trisomy is what we call as megacystis. Remember, it's megacystis, not cystitis, as some people say. It's megacystis. And this is defined as the longitudinal diameter of the bladder of more than 7 millimeters. And if the bladder diameter, longitudinal diameter in the first trimester is somewhere between 7 and 15 millimeters at 10 to 14 weeks, remember there's a 25% risk of either trisomy 13 or 18 in those fetuses. So you could look at it in the longitudinal view, in the coronal view, in the axial view. Any of these would tell you the longitudinal diameter being more than 7 is a classical finding in megacystis. We then look at the hands of the fetus in the first trimester. Remember, the hand is the eye to trisomy 18 and 13. The classical findings that you would find in trisomy 18 are clenched fists, overlapping digits, and a pointing index finger sign. Whereas in trisomy 13, the classical differentiating feature is post-axial polydactyly. Remember, the findings of trisomy 18 are not so evident in the first trimester. It's rather the findings of trisomy 13 that you would see very clearly in the first trimester. Now, the classical finding, as I said, is post-axial polydactyly, which means you will have a little finger beyond the little finger. That's a sixth finger that you see here in this picture. This is very easily picked up in the first trimester because that is the time the fetuses tend to show a very clear open hand to the ultrasound probe. Now, the other feature that you would associate with trisomy 13, of course, is the radial club hand. Now, this again is a very classical feature of trisomy 13 and not so much of trisomy 18. Lastly, we come to the feet in the first trimester. Here again, the finding that you would identify in the feet is the polydactyly in a fetus with trisomy 13. Sometimes you might also notice talipes or talipes equinovaris or rocker-bottom feet, which is much more common in trisomy 18 than with 13. But of course, in the first trimester, this is a very inconsistent finding. You may or may not see this in some or all fetuses. And sometimes the fetal position could be such that the fetus tends to show a talipoid kind of a appearance to the feet. But if this is a persistent finding, is when you would consider this as significant. So what we've seen so far is in the brain, if you find holoprosencephaly, it's more of a clue towards trisomy 13. If you find a midline cleft, it's again more of a clue to trisomy 13, but also could be seen in trisomy 18. Cardiac anomalies are seen in both. It's quite difficult to differentiate based on the nature of cardiac anomalies. Exomphalos is much more a feature of trisomy 18 than 13. Megacystis could be seen with both, but slightly more predilection towards trisomy 13. Hand abnormalities, the clenched fist and pointing index finger of the trisomy 18 fetuses are difficult to pick up in the first trimester. Rather, it's the post-axial polydactyly that you would identify in fetuses with trisomy 13. In the feet, again, you could find talipes or rocker-bottom feet in trisomy 18 and 13. And if you find polydactyly there, again, it's more of a clue towards trisomy 13. So in the first trimester, a growth-restricted fetus with increased nuchal translucency, additional aneuploidy markers, normal fetal heart rate, congenital heart disease, with or without exomphalos or megacystis, think of trisomy 18. On the other hand, if you find a growth-restricted fetus with again increased nuchal translucency, additional markers, but tachycardia, remember tachycardia, holoprosencephaly, facial clefts, particularly midline facial clefts, congenital heart disease, polydactyly very specifically, and or megacystis, think of trisomy 13. Now the question is, how good are we in diagnosing these in the first trimester? Well, it depends on how good a scan you do. There are papers that have looked at this, and I've picked up just one of these papers, and which very clearly said that if you do a good fetal NT and a detailed anomaly scan following the ISWOG guidelines for the first trimester scan, where you look at all of these structures that I've shown in the picture, and you add on to that the nasal bone, tricuspid, and ductus venosus flow, then you could identify about 95% of fetuses with trisomy 18 and 13 in the first trimester itself. So that leaves us with just around 5% of babies that go undetected in the first trimester to be picked up in the second trimester. And that's the reason I've devoted a lot more time to first trimester pointers than second trimester. And second trimester is basically just an extension of the findings that you found in the first trimester. Very similar pattern of systems involved. Of course, not really much to differentiate between trisomy 13 and 18. Very similar features, but slightly different proportions therein as well. Here again, the classical clue would be a very symmetric growth restriction pattern seen in more than half of these babies with trisomy 18 or 13. Some specific findings that you would see in the brain are, say, for example, a choroid plexus in the fetuses with trisomy 18. Some oftentimes very large multiple choroid plexus that you would see. Seen in around 30 to 50% of trisomy 18 fetuses as compared to just 1 to 3% of euploid fetuses. And remember, if these are isolated and you don't see anything else that's related to trisomy 13, normally growing fetus, then PPCs or choroid plexuses have no significance and they do not increase the risk of trisomy 18. But When you find them with other features that we're going to see, and we have already seen in the first trimester, that's when CP cysts are a very specific pointer towards trisomy 18 than trisomy 13. Now, the other classical finding that you associate with trisomy 18 is what we call as a strawberry-shaped skull. Remember, if I freeze this picture and put a strawberry in there, that looks exactly the same. So that's the strawberry-shaped skull, where you have a broad forehead, a brachycephalic skull with a pointed forehead. That is very typical of trisomy 18 as well. Whereas in trisomy 13, here again, as we said, it's midline abnormalities, and the classical abnormality remains that of holoprosencephaly, where you have an uncleaved cerebral mantle, as you can very clearly make out here. Uncleaved diencephalon, the uncleaved thalami gives you what is called as a heart shape or a heart sign. And of course, you could have a large monoventricle and an even larger dorsal sac or dorsal cyst in some of these babies with trisomy 13. Of course, the 3D helps you bring this out much better as well. The other clue to some of these aneuploidies is what we call as a wide CSP, where the ratio of the width is much more than the length. Now, this has been proven time and again that this could be a marker for trisomies, but particularly trisomy 18 shows a very wide range of CSP, than a wider CSP than trisomy 21. Even trisomy 13 shows CSP is wider than the normal fetus. So that is again a significant clue that you could look for in the second trimester. Of course, it has also been linked to Dibuat syndrome, but you would always read it in conjunction with the other anomalies that we described. Now, the other clues to trisomy 18 in the brain could be a cerebellar or a pontocerebellar hypoplasia. You could have a megacisterna magna, and these are again very, very subtle clues, but could draw your attention to the possibility of a trisomy 18. Now, having said that, midline abnormalities in trisomy 13 could also be agenesis of corpus callosum, because that again is a midline structure, but the classical finding was the holoprosencephaly. We then come to the face. Now, trisomy 18 fetuses have a very peculiar face pattern, as you can see in this picture. If you have seen enough of them, you might probably be able to identify them on ultrasound as well. And classical example, there would be a low set misshapen ears, as I've shown in this particular picture here. The other clues to the face, to trisomy 18 from the face in the second trimester are hypertelorism. Sometimes you could see unilateral clefts, and of course, the finding of micrognathia would still persist in the second trimester. But if you talk of face in trisomy 13, we said it's midline abnormalities, and all the facial anomalies that you would associate or attribute to holoprosencephaly are also seen in trisomy 13, there being hypertelorism. Arrhynia, remember in trisomy 18 it was hypertelorism, in 13 it is usually hypotelorism that you get. Arrhynia, phoebocephaly, where you have a single nostril, cyclops with the proboscis, all of these are findings that you would attribute to holoprosencephaly, and in trisomy 13, both holoprosencephaly as well as the facial anomalies would be very clearly seen. And of course, not to forget the fact that you could find a median cleft lip as well in fetuses with trisomy 13. You come down to the thorax, the classical finding, again attributed with trisomy 18 is a diaphragmatic hernia or an eventration of the diaphragm. As you can see, the liver is up in the right side of the thorax and sitting by the side of the heart in this particular video. Now, talk of heart, we said that there could be a host of anomalies that are seen with the heart. You could find VSDs, AVSDs, hypoplastic left heart, double outlet right ventricles, TOF, TGS, pulmonary stenosis with TR, and of course, coarctation of the aorta. As I said, there's not much to pick and choose between these anomalies, but as I said, DORV is very specific for trisomy 18, and AVSDs with left ventricular outflow tract obstructions are a hallmark of trisomy 13. But remember, these are not watertight compartments. You could have both of these in both the trisomies. But what is important here is that you do a very thorough examination of the fetal heart anytime you suspect trisomy 18 and 13 by a sequential segmental analysis so that you don't miss out on a cardiac anomaly. Coming down to the renal system, of course, cystic renal dysplasias, echogenic kidneys, horseshoe kidneys, any of these could be seen with both trisomy 18 or trisomy 13, but these are mostly associated with trisomy 13 than 18, because again, remember, it affects the midline and structures on either side of the midline, which is why both the kidneys tend to get affected more in trisomy 13, in fact, much more in trisomy 13 than in trisomy 18. The other clue could be abnormalities of the umbilical artery, sometimes a single umbilical artery, as you see in this picture, again associated with trisomy 18 more commonly, or umbilical cord cysts, which could be seen with both trisomy 18 or trisomy 13. Again, more commonly with trisomy 13. Now, coming to the hands, exactly the same thing that we spoke about in the first trimester, but here the findings of the clenched fist, overlapping digits, camptodactyly, and pointing index finger are much more obvious in the second trimester. And these are very typical findings. In fact, if you ask me, the most specific finding of all of these that I've discussed for trisomy 18 would be these abnormalities of the hand. Remember, these are very subtle, so unless you really search for these and seek for them, it may completely escape detection. So unless you know that this is a very hallmark, very significant finding of trisomy 18, you might not really look for them. But if you look for them, most cases you would find this in trisomy 18 fetuses. That's the pointing index finger. Sometimes it could be completely open like that in pointing. Sometimes it could be bent like that in pointing, but it's a very typical feature that you have clenched fist, overlapping digits, pointing index finger sign, very specific of trisomy 18. On the other hand, you talk of trisomy 13, the most common finding is again a post-axial polydactyly, as we spoke about in the first trimester. Coming to the feet, 18 and 13, both of these could be associated with talipes or congenital talipes equinovaris, or flat foot, club foot as you call it, or sometimes you could find rocker bottom feet. Again, the classical clue would be that you would not find the medial plantar arch, rather you would find a projection in the medial aspect of the foot, and sometimes you might just find a flat foot, but when you look at the sagittal sections, you can very clearly make out the rocker bottom feet with a very prominent heel sitting there. Another case where you find that the only thing that you would notice is that there is a flat foot with a complete loss of the plantar arch, but when you come to the sagittal, then you can very clearly make a diagnosis of a rocker bottom feet. Again, very subtle findings. Unless you know for it, unless your mind knows it, you will not really look for it, and if you don't look for it, you would not see these findings. So in the second trimester, we find a growth restricted fetus with CP cyst. Always try to look and seek out for the other markers. Could be very subtle. For example, strawberry skull could be very subtle. You might find a slightly smaller cerebellum. Of course, cardiac defect you would not miss. Diaphragmatic hernia or eventration could be very subtle, especially if the stomach is intra-abdominal. But come and look at the hands and the feet. If you find clenched fist with overlapping digits and pointing index fingers, it's talipes or rocker bottom feet, very likely that you're dealing with a case of trisomy 18. Whereas on the other hand, you have a growth restricted fetus with holoprosencephaly, classical midline abnormalities, midline clefts, cardiac defect, renal anomalies, and of course, with the addition of polydactyly, post-axial polydactyly, and talipes or rocker bottom feet, always think of trisomy 13. So again, the same question, how good are we in diagnosing trisomy 13 and 18 in the second trimester? Again, lots of papers, I've quoted a few. This paper says, in experienced hands, the sensitivity is 100%, which means all cases will have anomalies, and if you know what to look for, you can definitely pick up trisomy 18 and 13 in the second trimester. I would end with this last slide. I really like this editorial that came in the White Journal, where they said that there have been significant advances in ultrasound over the last 10 years. Today, a normal thorough sonogram in experienced hands can essentially completely rule out the presence of trisomy 18. So it's time to stop using standards that were devised when ultrasound was in its infancy to determine management of patients with a positive serum screening, which means he or she is saying you really don't need to do an invasive testing, but you can be very specific in your diagnosis of 18 and 13 if you do a good level 2 scan in the second trimester. The old habits die hard, but we must be willing to move ahead when the evidence tells us we should. Thank you very much for a patient listening.